Public dialogue and civic engagement are important. They play a role in improving the health and well-being of Texans across our great state. That's why Blue Cross and Blue Shield of Texas is proud to support Texas Tribune conversations like the one you're about to see.
Thank you. Thank you to Dr. Ray, and thank you to Texas Women's University for hosting the event. Also, thank you to Suella Mueller and Carlos De Silva for helping us organize the event. And thank you to Blue Cross and Blue Shield for presenting this, which is the third event of a 3-event series that we've had on healthcare this year. Would also like to thank a few of our sponsors: Fibertown, Community Health Choice, the Meadows Mental Health Policy Institute, Central Market, who provided today's lunches, the Houston Endowment, and Southwest Airlines. Though donors and corporations contribute to Texas Tribune events, they do not have any say in the content of the actual events or panelists. Just want to remind everyone to go ahead and silence your cell phones. And for those using Twitter, we use the hashtag TTEvents. This will last until about 1 p.m. and we'll have 15 minutes. That will include 15 minutes of Q&A after the panelists have spoken. And we have a really, really good panel today who really know their stuff. And I'm hoping we can fit all of their knowledge into the allotted time. Directly to my left is State Rep Sarah Davis, a Republican from West University Place. She also chairs the Appropriations Subcommittee that basically works on the state budget for Health and Human Services. And then we have Elena Marks, who is the President and CEO of the Episcopal Health Foundation. And next to her is Umair Shah, Executive Director of Harris County Public Health. And I'll actually go ahead and start with you on the end. When you talk about a disaster, or when you think about a disaster like Harvey that affects so many people, what all does it take to logistically get healthcare in place, the healthcare infrastructure up and running during a disaster, and to prepare for just the influx of displaced people that you're going to see?
Thank you. First of all, thank you for pronouncing my name correctly. So that was my first. Yeah, thank you. I saw the practice there.
I practiced.
So thank you for having me on the panel, Brandon. Thank you, and Texas Women's University for having this panel. I think it's a really good time to have this discussion. We're 95 days, if I'm correct, maybe 96 days post Hurricane Harvey hitting the Texas coast. And as we all know, this was a devastating storm that hit not just Houston, Harris County, which is what we're focusing on, but certainly the entirety of the Texas coast. And many, many communities were impacted. And I think we have to remember that those communities were impacted in a number of different ways. And health, public health was an incredible component of it, but there were so many other areas that were impacted. The answer to Brandon's question really is the fact that there has been an incredible amount of investment that has been made by our community and our health or healthcare system. Our health and healthcare system, not exactly the same. So just want to make sure to clarify that, and I can certainly clarify that further really over the last 15, 16 years. So Tropical Storm Allison was 2001. Hurricane Katrina, right? This was a storm that didn't hit us. It hit, obviously, our neighbors to the east, but we took 27,000 at the Astrodome, another 38,000 that were moved processed through the Astrodome complex. We had Hurricane Rita, where we were then deciding how to get everybody out of harm's way, but the hurricane didn't hit us. 2008, now you had Hurricane Ike that did hit Galveston and Harris County. And then you had the storms over the last couple of years with the Memorial Day floods of 2015, the Tax Day floods of 2016, and then certainly Hurricane Harvey. And the reason I go through all that is that when we go back to Tropical Storm Allison, when I was an emergency department physician at the VA hospital, there was an incredible amount of discussion at that time of how we needed to improve our healthcare system, how we needed to really buttress the hospitals in this very Texas Medical Center to ensure that we didn't have what we saw at that time, a lot of institutions that were underwater or people could not get to those institutions. Now you transform yourselves 15 or transfer ourselves 15 years ahead, and what we have now is a system that really did invest in that health care equation. And that means that we did things like not putting the generators in the basements, that we had pumps and drainage systems that allowed for hospital healthcare institutions to be able to really to perform well. During Hurricane Harvey, we have 120 plus healthcare institutions in the community. Many of those are nursing homes, many of those are smaller institutions. Less than 10% out of 120 plus, less than 10% of them went down or needed to evacuate their patients. That is remarkable for the fact that we had an incredible amount of rain in this community, and yet our healthcare system was able to survive that. But that healthcare system was supplemented by the health system, the public health system. And we've made an incredible amount of investments in our health system as well, not just with these storms, but with the H1N1, Ebola, Zika, and a number of other diseases that we've had as well. And so when you take the healthcare system and the health system together, we have really invested in our healthcare system to be strong, to be really agile, and to be nimble. The county, Harris County, under the leadership of Judge Eccles initially, Judge Emmett now, and County Commissioners Court and all the county agencies, along with our partners at the City of Houston, really worked hard also in making sure that there was an incredible amount of investment on the governmental side, not just the health side and the healthcare system side, but the governmental side. All of that comes together in investing for a community when it has a crisis as large as Hurricane Harvey.
It sounds kind of like with every storm you learn lessons and build on those to prepare for the next one. Are there already lessons from Harvey or issues that came up during Harvey, or weaknesses in the plan that y'all have identified that y'all are trying to fix before the next storm?
Yeah, I think your point is that we're always looking at continuous improvements of what we've done. And so one of the biggest challenges that we had is that when you have a large-scale evacuation or people that are in harm's way, you need to get them somewhere. And so we know that the American Red Cross opens up shelters. It doesn't always work as well in those shelters that are spread throughout, and how do you coordinate all these smaller shelters? And so there's been this discussion over time, and we've seen GRB, George R. Brown Convention Center, that was open from the City of Houston, NRG, the former Astrodome complex that was opened by the county. And so the real concept is, well, how do we now not just say ad hoc, we're going to open something up, but really start to think about, do we name a facility, or by default think of a facility that's going to likely come in play when you have an emergency such as a Hurricane Harvey. The other piece is that we've also learned, and this is where I'm going to segue into the public health side, that one of the biggest challenges you have is that when people come into the healthcare system, you can start to measure their diseases. You can start to measure the respiratory disease, the GI disease, the skin infections, and all the mental health issues. The challenge is, during Hurricane Harvey, people couldn't get to the healthcare system, not because the healthcare system was down, but because they were down, or their cars were flooded out, or the roads that to get out of their neighborhoods to get to anywhere, they were unable to. So the challenge is that when people are actually now going back to their homes and really ensuring that they're gutting out all the things that they can, and they're not worried about their own health, they're not thinking about going to check into their healthcare provider. When that happens, it's hard to measure what's the illness rate, what are the amounts of infections, what are the amounts of mold and mildew, what are the amounts of injuries, what are the amounts of skin infections, and go down the list How do you do that when you're in the community, when people don't have that system in place? Do you go knocking door to door, which is what Harris County Public Health did? Do you do surveys, which is what we did? But how do you do that for 4.5 million people? That's a big challenge.
I mean, one of the things I'm learning from covering the relief efforts is just how complicated it is after a disaster, especially one this big, and how there's limited amounts of resources to help a city or a community recover. And one of the things you touched on is, making sure generators aren't in basements and focusing on the physical infrastructure, and a lot of times using disaster relief money to prepare for the next storm. I wanted to ask you, Elena, I mean, is the public health-wise, is that the only thing or just healthcare-wise, that should be focused on is, making sure the physical infrastructure is okay, making sure that there are systems and processes in place? Should that be the sole focus?
No, it shouldn't be the sole focus, and I agree. We tag team on these kinds of things a lot. I agree with everything that he said, and the way that this community has improved its ability to withstand storms in terms of healthcare delivery is remarkable. And we are really expert in this community in emergency situations, even when systems are down, pulling together and providing, frankly, in some cases, better health care than we do on an ongoing basis when we're not in an emergency situation. But what we are going to see, what we're already seeing in terms of once you're past getting people not to die immediately after a storm, is that we have a lack of social capital and social infrastructure that leaves people extremely vulnerable before, during, they actually get a little lift during, and then after a recovery. And our focus on health care, terrific. I'm glad that we stood up a fantastic system. That's the tip of the iceberg. If you look at what builds a healthy community, what makes an individual, a family, a neighborhood, a city, a county healthy, the investments that you make in healthcare actually have a much smaller impact on overall health outcomes than the investments you make in social and community infrastructure. And so we can pat ourselves on the back a lot for doing, we get an A+ in healthcare in this community, for some people, actually, and truly only for some people. We get a really poor grade in this community on building the kinds of human capital infrastructure that help people before, during, and after in building resilient communities. And we can pat ourselves on the back all day long about the great physical and mental health care we gave people and can give people, and it completely begs the question of why the health outcomes in our community are substandard and are not moving in positive directions.
What are you calling social capital, social infrastructure?
I'm talking about how people relate to one another, whether there is equity, whether there is inclusion, whether people have safe housing in the first place, whether people have financial security, whether people have access to public institutions, whether people have their voices represented, whether we have a clean environment in terms of air, water, and soil. And all of those things, when they break down, we try to fix them in the healthcare delivery system, but the impact of investing in real community health is different than investing in healthcare delivery, and we are spending way too much time and money on the healthcare medical services piece, and we are really underinvested in what in the field you would call social determinants of health, but I would just call determinants of health. You're the one who told me to stop calling it social determinants, because there's decades of research that quantify what it is that contributes to health outcomes in terms of life expectancy and quality of life. and medical services is a very tiny percentage of it. And yet in this country, in this state, in this community, we are obsessed with investing in medical services, and we are doing that at the expense of investments that actually would produce better health outcomes. And when you put an equity lens on it and look at people in lower socioeconomic categories, minorities, immigrants, women, and you can look at the maternal mortality rates to get a little view of what we do or don't do to and for women in this community, we're not taking care of the things that actually lead to healthy people, healthy families, and healthy communities. We're great once you're like really, really sick. You know, you can go to the med center if you can pay and get great treatment. Otherwise, the chances to live a healthy and productive life are stacked against you.
Where's the breakdown there? I mean, if there's decades of research showing the way, like why?
Well, so my opinion on the breakdown is it's historical. If you go back to the mid-20th century, the advances that we have made in medicine and technology are phenomenal. I mean, we have knocked it out of the ballpark. We are really good at that. And we as a culture and we as a economy have significantly invested emotional and financial capital in building more and more of that. And in the last 20 years, there's been this recognition of, oh, wait, that can only take you so far. There's all this other stuff that's going on that actually has a bigger impact on health outcomes than all of this extremely high-tech medicine. And that's not even accounting for medical errors, overutilization, high prices, et cetera, et cetera. And so what we're trying to do in this country very slowly is right this ship by recognizing that what we want to pay for is value in health and not medical services. And that's really hard to do because we have a lot of emotional and financial capital, trillions of dollars, that are locked up in a system that we started creating when we believed that was the way to go. And so now we're going, oh wait, yeah, no, I know you were going to build the next robotics, this, that, or the other, but that actually is not so effective. Let's do something different. And so it is going to take a long time, and we're seeing the shift actually from the federal government, and this began a long time ago, and it's not a Democratic or Republican thing, but the concept of value-based care and whether or not we are actually getting value. We spend way more than any other country on medical services, on health care. Our health outcomes are at the very bottom, and so we are not getting value for the money we spend. And so the system is finally, the payers actually, Medicare, large employers, insurance companies are starting to say, wait a minute, what are we getting for all of this money? We're not getting good health outcomes. We may be getting a lot of medical services, we may be getting a lot of drugs, but we're not getting good health outcomes. And you can use the maternal mortality issue, which Sarah can address really well because she's been a terrific advocate on it, as sort of a microcosm of looking at what happens when you are maniacally focused on very high-tech, high-touch, expensive medical services at the expense of all of this other stuff that actually produces health outcomes.
Representative Davis, the district that you represent, I mean, the flooding there was, I mean, devastating in some neighborhoods. Since the storm, what have you heard from your constituents that they need as people start moving into long-term recovery, what they need healthcare-wise?
My district is a quite unique district. I mean, it does encompass the Texas Medical Center, but it is also the wealthiest district in the state. And so a lot of the needs that I am hearing from my constituents aren't necessarily regarding healthcare, but regarding how come the insurance company isn't, doing what it's supposed to be doing, and where is FEMA? So what I hear though from constituent institutions, including the medical center, I hear a great deal about Harvey concerns. One of the first things I thought of was Medicaid. You know, we honestly shortchanged Medicaid in the state budget by $1.5 billion. And we don't allow for cost growth. Now we allow for enrollment growth, but enrollment in Medicaid's been pretty stagnant. So we know going into the next session, we're gonna have, what, $2 billion maybe shortfall in Medicaid, and as that results to Harvey, HHSC has been transferring money to programs in response to Harvey. And so they're taking money that was appropriated for, let's say, 2019, and they're spending it in 2018, or they're, you know, spending it now. And that's not, I mean, they have the approval to do that, but we're just digging ourselves into I think a bigger and bigger Medicaid hole. So I think that's the first thing that I think of when I'm thinking Harvey effects on healthcare is Medicaid.
So that $2 billion shortfall that y'all were going to be facing when you go back to Austin in 2019, that was before Harvey?
That was before Harvey.
Is there an estimate of what it's going to be now, or is it going to?
I don't have that.
Okay.
I don't have that estimate, to be honest with you. But it could be pretty significant. I think mental health is going to be, you know, I do hear from constituents who, you know, they're starting to notice different behavioral changes in their kids, and they're at, you know, these are very, you know, upper middle class, wealthy, but they still lost all their homes and all their belongings. I mean, my district was not spared. I represent Meyerland, where we had 1,900 out of the 2,300 homes flooded out. 40% of all structures in Bel Air were flooded out. I mean, Braeswood. So my district was not affected, even though it isn't you know, you wouldn't consider it to be a poor part of Houston. But the mental health aspect of this is going to be significant. I was looking at some information that provided by the Meadows Foundation, and what they are saying based on a post-Katrina analysis is that at about 18 months out is when will be the peak for mental illness. So 18 months from the 5 days of Harvey. At ages 5 through 11, the post-traumatic stress syndrome rates are going to be 5 to 7 times higher. And the rates of other SMI or severe mental illness is 60% higher. And then if you're ages 12 to 17, the adolescents, the PTSD rate is 3 to 4 times higher, and other rates of severe mental illness is 2 times higher. And then for adults, you have 4 times higher rates of PTSD and 50% higher rates of severe mental illness. So we are seeing, you know, children start to exhibit 60 to 90 days out. Well, we are at 90 days, and we are starting to hear some anecdotal evidence of behavioral changes in children and children struggling in school. And this is just the beginning. So if the peak is going to be in 18 months, and you know, we have hundreds of thousands of children that were affected by this, I think that is going to be one of the most significant health care ramifications of Harvey is going to be in mental health. You know, we've had, how many Superfund sites were flooded? Were there like 5 Superfund? So that makes me think of different exposure, you know, environmental exposure, that diseases that I think we're going to see, and I'm not an expert on any of that, so I couldn't even begin, but I just know that we're going to see with the chemical plant. I mean, we have first responders saying that they're sick, but I think that these Superfund sites are going to generate some pretty significant public health implications. And then I always like to listen to what Dr. Hotez writes and says, and he has reminded me in an article I read that the West Nile virus cases doubled a year after Katrina. Mm-hmm. So mosquito-borne illnesses, I think, could be very significant. And that again, those affect everyone, not just, you know, all over the county.
I have like 100 follow-ups to what you just said. Don't even know where to start. Is that something that y'all are looking at for next year? Is like an uptick or a huge spike in mosquito-borne illnesses, or something like that you're preparing for next year?
So Representative Davis brings up a number of really good points. So I agree, it's very hard to follow, but of course that's the first thing that he does is he punts it back over to me to try to follow.
So, I'm a politician.
There you go. Yeah, there you go. Well, and you're absolutely right about the mosquito-borne diseases. We Harris County Public Health has the mosquito vector control program for that provides services for the entirety of the community, including the city and the county. And the reason that's important is that we were very, I don't know if it's the best word, but it's the right word, aggressive post-Harvey when it came to, let me back up for just a second and put this bottle down. So what happened with, it's hard, I'm a really kind of move my hand type of guy. So when Hurricane Harvey, and that water was cold, Hurricane Harvey, when it hit, we actually had to move our mosquito traps out. And the reason you have to do that is because water is coming. You don't know where those where the water is going to be coming, and those traps will then get completely ruined. These are the traps that actually collect the mosquitoes. So we removed all these traps throughout 1,778 square miles, right? A size larger than Rhode Island. We removed those traps. So paradoxically, right after Harvey came, you actually had a decrease in West Nile virus risk. And the reason you had a decrease was, guess what? You need for West Nile virus. You need humans, you need mosquitoes, but you also need birds. And guess what birds decided to do when they saw this hurricane coming? They're like, oh, I'm out of town. I'm going north. So they took off elsewhere. So you actually had a decreased risk of West Nile virus that initial period of time. But we knew we needed to get our traps back in, which is what we did over the first several days post-Harvey. But we also had to be very aggressive with ground spraying, which included 1 million acres of Harris County. That's how many acres we have in Harris County. Our ground trucks can do somewhere between 15 and 20,000 acres of ground spray at night in any one night. So we would have been doing this till the cows come home and never gotten all the areas. So we went ahead and worked with the state and accepted their offer, as well as a partnership with the federal government. So it was a federal, state, local partnership where we had aerial spraying. And aerial spraying was able to get up to 200,000 acres a night. So now you think about the scope and scale. With 3 or 4 nights, we were able to cover a remarkably larger part of Harris County. And the reason why I bring all this up is that we really recognized that West Nile virus was going to start to be an issue in that first 10 to 14 days post-Hurricane Harvey. When the water finally left, we knew that eventually the water would stay and we would have mosquito breeding, and that when you had debris piles, that was also now going to start to become a breeding ground for mosquitoes. So we were very aggressive. What Dr. Hotez is pointing out rightly is that 6 to 12 months later, during Hurricane Katrina in the Gulf Coast, you had an increase in mosquito-borne diseases. That was one of the reasons that when a lot of individuals were hearing about aerial spraying, they said, well, why are you being aggressive? When we were doing ground spray, why are you being aggressive? And that's exactly why we were being aggressive, is that we recognize that if you don't get ahead of this now, you do have an increase in mosquito-borne diseases afterwards. And so that is a concern that we have, but now with our traps back, we're doing an incredible amount of surveillance, which a lot of communities in the country, unfortunately, do not have those capabilities. So that's one of the benefits of being in Harris County.
Let's talk mental health for...
I just want to thank you for doing all that and being so aggressive. And I also want to give Dr. Shaw a huge thanks because he helped me coordinate a caravan in Meyerland where we were able to administer, I think, over 500 Tdap vaccines, because that was one of the first issues that I thought of when the waters receded and everyone's cleaning out their house. Oh my goodness, how many of my constituents have had their Tdap booster? Probably very few. And so I really do appreciate getting to work with the county on making sure we were getting our booster shots.
Well, thank you for saying that. I actually wanted to do a quick shout out to Mac McClendon. Mac, if you can raise your hand. He's the biggest guy in the room, but whenever I call him out, he always is the most sheepish about. Mac is our director of the Office of Public Health Preparedness and Response. He, Jennifer Kiger, Les Becker, and our executive team were very instrumental in all of the kinds of things that you just described. Is it okay to call you Sarah? Should I say Representative Davis?
Yeah, Sarah.
Okay. And really,
I might not respond.
yeah, there you go. But the reason I bring that up is that it really, at the end of the day, is about team. And the way we were able to get through Hurricane Harvey was the team of Harris County, and I mean the community, the team of community coming together. But Elena is absolutely right. We have a lot more work to do to ensure that the next time we have these kinds of emergent, and we are going to have another emergency, it's just a matter of when, that we're ready for those, because we have to remember that we can't just rest on the laurels of the last storm. We have to think about what the next storm is going to be.
But I do think it's really important to remember and thank all of the healthcare providers, all of those ride-out teams that were there for 5 days straight, 7 days straight. And when you talk about preparing for Harvey, if you look at what the Texas Medical Center did, I mean, it really is just a national example of how to prepare, whether it was the $50 million investment for flood control with the floodgates, not having, generators, below. I mean, the physical aspect or investment was obviously an amazing return on investment. I mean, I think Harris Health suffered a total of $12 million in Harvey damage. And if you think about Allison, I mean, it's incredible return on investment. But the people, I mean, the stories of nurses canoeing in to the medical center to take care of their patients, doctors not leaving, or if they were leaving to go to a shelter to help care for people in the shelters was really, I mean, I cannot stress how important that was for the health of the community and for the reputation of the city, for the city of Houston, that we can come together and handle these things. And I mean, I think we learned a lot of lessons, going forward legislatively. One thing I think about is I heard that these freestanding dialysis centers, there's really no regulation. They don't have to have backup generators. So they just closed and went home and had left, thousands of dialysis patients with nowhere to turn but an emergency room, if they could get into the medical center. And obviously, an emergency room is not the place for dialysis treatment, but it's also not the place to just dump homeless people, right, which was a problem. There needed to be, I think, some future thought given to medical shelters specifically. So I think there's been a lot of lessons learned, and I think legislatively there's some things that we can do. But I just don't want anyone to leave today without feeling so proud of Houston and our healthcare providers and our institutions. And the collaboration was incredible. I mean, all the hospitals were on daily calls with each other, communicating at all times, which is another thing we need, probably better IT infrastructure. Relying on social media is not, the best. But it really was a phenomenal job that took place in the medical center. Street flooding kept people away, but I mean, I just want to make sure we all, thank all the people that were there for 7 days.
The numbers you brought up on mental health, some of those were pretty surprising and stark. It sounds like there could be like this coming wave of mental health issues in the long term. Is the community, and I don't just mean like the healthcare community, but I mean the community at large, like ready to deal with that, to identify, what, some, signs are that somebody's having mental health problems? I mean, is this something that y'all are worried about? What are you doing to prepare? What can the community do to prepare?
My big answer is no. I'm going to say no. You know, I'm really tired of us talking about mental health as if we have solved it. We have not solved it. Mental health is one of those hidden areas that we continue to brush under the rug. We talk about diabetes, we talk about hypertension, we talk about cardiovascular disease, we talk about infectious disease, we talk about Ebola and Zika. But mental health is a serious problem in our community, and that's before Hurricane Harvey ever hit. Now you have a number of people who have been impacted by the storm, and you're having difficult conversations. So here's a health official saying, oh, you know what, when in doubt, throw it out. So now people have thrown all these things out, and their debris is on their front lawns, and then you have a parent who's having to tell a child, yeah, I had to throw your favorite toy away. And now the child is having to face another mental health issue based on the fact that now they've had something that's been thrown away. And we don't have those capabilities, not just in this community, in this state, in this country, in this globe. Right now, globally, we do not have a mental health system that even works. We have to stop talking about mental health as it being separate from physical health. It is a holistic system, and mental health is not getting the kind of recognition, but it's also not getting the kind of attention that it needs in order for us to get the very basic recognition of patterns of what people are going through. And that is going to be a continuing challenge for us. And I'm really concerned that mental health is going to continue to get worse, but Hurricane Harvey is going to accentuate that. And if we don't get to really having significantly strong and real conversations, the political will and the public will to take on mental health as it should be taken on. Let's not even bring up substance abuse and opioids and all these other. We are going to continue to have that question asked, and we're going to say, yeah, well, we're kind of doing a job, but we are not.
Well, while I agree with a lot of what you said, I will say that the Texas House of Representatives takes this issue very seriously. Under the leadership of Joe Strauss, we had our select committee to study mental health care that was chaired by Fort Price. I ensured hundreds of millions of dollars in funding in the Article 2 budget for mental health. The Speaker has created a committee to study opioid abuse. So mental health and substance abuse have long been priorities of the Texas House, and not only with policy, but with money. And I can vouch for that because I write that part of the budget. And I will also say that there has been the TEA has established the Hurricane Harvey Task Force on School Mental Health Supports, because I agree. You know, who's there? Who's going to identify these kids that are having mental health? And it's obviously going to be the schools. And so I was very pleased with Commissioner Morath creating the task force. They're working in connection with the Texas Higher Education Coordinating Board, as well as with Health and Human Services Commission and with the Meadows Foundation. So I believe that on a state level, from the House side, that mental health has been a priority for a long time. And in fact, we are taking steps to try and identify and get help to those to children who have been the victims of Harvey.
What about from the Senate side?
I have no comment.
So the lack of mental health infrastructure.
Beg to be asked.
The lack of mental health infrastructure, I would say, is a symptom of lack of attention to anything that isn't part of high-tech, hospital-oriented care, that we have focused all of our health brain around that, and we have neglected the kinds of things that make human beings resilient. And so we will all be up in arms post-Harvey, and yeah, these kids are going to be upset and their toys have been thrown away. Long before that happened, we have people who live in under toxic stress day in and day out, because the community conditions in which they live do not allow them to get beyond the stress that is pouring cortisol over their brains and disabling them from developing normally and having a healthy, productive life. And so if we use Harvey as an excuse to look at this, I guess that's good, but we have a much bigger problem than what we're going to do in response to Harvey. And it goes back to cuts that the state made quite a while ago, and all of the recent addition of funding that the state has put into mental health has been great, but it's replacing a hole that it dug. And so if we don't acknowledge that we have to invest in people and not just in buildings and not just in business, we're not going to get past this, and we're going to keep on having situations where human beings are too vulnerable going into their day-to-day lives, and particularly when they come out on the other side of any kind of event. And so if we can use Harvey as a wake-up call, because frankly, as we know, the healthcare infrastructure really wasn't harmed, and the healthcare infrastructure can only do so much to promote healthy communities. If Harvey becomes an excuse for addressing some of those problems, that would be fantastic. But if we put it in the, oh, we did this because kids were affected by Harvey, and we go back to the way things were before Harvey, they were pitiful. We were raising kids who are not going to be successful in life, and it's our own fault, and we can do better than that, and it requires attention to an investment in something in the health sector besides medical services. And I'm sorry to be a broken record on that, but
I just want to also make sure that you know that the Senate had to approve the budget with all of that mental health care money in it. So.
Okay. And I do want to maybe if I can merge both of these viewpoints, is the real concern that I have on the public health side is that as we're talking about Harvey and we're looking at whether it's at the discussions that are happening at the federal level or even discussions that are happening from Texas or Florida or et cetera in Washington, if you will, that public health is not a part of that. And that's a really big concern that I have, is that when we're in the middle of a response, we lean on public health and health departments to be first responders, as Sarah had mentioned very nicely. First responders, first responders, first responders. And then when it comes to policies and funding, we want to make sure that law enforcement and fire and EMS and healthcare, that they are adequately funded, and that we respond by making sure their capabilities are agile and strong and more capable than ever. But there's that fifth finger here, the thumb of public health. And we don't include that public health as part of that. So we lean on public health during the emergency, but after the emergency is gone, we forget that the offensive line of a football team is absolutely critical to the success of that football team. And that's what public health is, the offensive line of a football team. So while the quarterback, the healthcare system, the running back, EMS, and the wide receiver, law enforcement, are getting and running around and doing all those things, and I support them and I want them to be successful, I definitely, and I feel strongly they have to be capable. I want to make sure that we're also investing in that offensive line, because if we don't do that, the capabilities at a health department at a local level, a state level, or even at a CDC or a federal level, those capabilities are just not going to be there. And so every time you have an emergency, you have to then be more reactive, and because the capabilities are here, not here, you have to stretch even further and even more reactively, think of Ebola funding, Zika funding after the fact, and not in advance to create those capabilities. So it's a really big challenge that I'm very concerned about.
And if you have to, a perfect example of what happens with public health can be seen in the 21st Century Cures Act that passed at the end of last year. Everyone's all excited, oh, more money for cancer, more money for cancer. That's fantastic. They took it from public health. And public health is invisible unless you need it. And public health is what cares about the population, all people. And public health is the group that is responsible for whether we have high maternal mortality rates, whether we have good outcomes, at the population level. Healthcare and medicine is a one-on-one thing where one patient is served and hopefully their life is improved, but the community, the population's health is in the hands of public health, and we have been watching as our healthcare providers have been asked to take a public health, a population health perspective, and they're getting a little bit better at it, but they're still healthcare delivery focused, and unless and until we can make that transition where we see health as based on health outcomes, we're going to continue spending money after the fact on medical interventions, and we're going to continue to underfund population health initiatives that can actually improve the health of large segments of the population. And when you talk about low income and minority populations and immigrants and marginalized populations, everything we've been saying here, multiply the badness by like 10 times, and then you see the impact on those populations. And it's not right and it's not fair. And it doesn't have to be that way. We are a wealthy state, we are a wealthy community, we are a wealthy country. We're not spending our resources in the way that is most effective for population health. And unless and until we're willing to do that, we'll keep on patting ourselves on the back that we got through Harvey because we have invested tremendously in healthcare delivery. We're terrific at it for those who can get to it. But then there's everything else. And I would suggest that the everything else in terms of population health outcomes is more impactful than what we're doing in the medical sector.
I could go on all day with y'all, but we do have limited time, and I want the audience to have a chance to ask y'all questions. And we actually, Agnes has a microphone and can walk around if people just want to raise their hands, and she's going to start right here.
Yeah, toward the beginning you mentioned there is a difference between healthcare system and health system. If you could just make us the distinction just slightly, just to be sure.
Yeah, thank you for asking that question. I had planted you somewhere in the audience just so you would ask that. Just kidding. So I think Elena's last comment really is what I'm referring to, is that we are very much talking about health care delivery. And in fact, the Affordable Care Act debate over the last several years has been about health insurance reform. But even if you give somebody access to health care or a way to pay for the provision of health care delivery, it's necessary, but it's not sufficient. Right. And that's where I really believe that when we're talking about health system, we're talking about health care delivery as not the umbrella under which everything else falls, but a health system, which is really a public health system that includes healthcare delivery, it includes mental health, it includes chronic disease care, it includes, and you go down the list. And the challenge is that we don't have a health system, again, mental health and physical health together, behavioral health along with that, substance abuse along with that. We don't have that system in this nation, and because we don't have that system, we're really left to oftentimes having pieces of the pie and really fighting on the size of the pieces, not really thinking about the whole pie itself, which is, I think, the biggest tragedy that we have here in this country.
Yeah, we talk about health care and not health. We ought to be talking about health. What we want is good health outcomes. Health care is one thing that helps attain good health outcomes, but it's the health that we're interested in, not the health care, except to the extent it's in service of health. And that's what a health system would be about, and that's where the public health perspective, the population health perspective, changes the way you look at it so that it's not about health care, it's about health.
And globally, it oftentimes you actually, in many countries,
they're much
it's
better
really
at
a
it
health
than we are.
system, and you're talking about what's happening under that umbrella, whereas here we've actually divorced some of those things into different silos, and now it becomes harder, including social services, by the way. Social services are very much divorced from health services, and so now you have education and housing and transportation, all the things that we're very much, we talk about all the time. But there are those determinants of health, and yet we don't have those integrated into a overall health strategy.
And we don't pay for them. We want to pay for health care.
Hi, Hank Jones. I'm a health information technology lawyer, researcher, and teacher. Ms. Marks mentioned in passing information technology. All citizens donated $31 billion to belatedly drag the healthcare industry to using software and computers after other industries. There have been presentations in the last few months at the Houston and Austin chapters of the Global Trade Association of Health, Infotech, HIMSS, analyzing what data was and wasn't available in systems in terms of patient records, et cetera. Some of us know that the THSA had unplugged its HIA, its software system, and then quickly had to reload it up and refire it up again for Harvey response over, I guess, in Austin. Do y'all have any specific assessments post-Harvey on where the data and software infrastructure of health systems, of patient records, et cetera, what we learned, where we were sufficient, where we weren't, where we need to change, please? Thanks.
I am seeing some interesting intersections between healthcare IT systems and health systems writ large. Those of you familiar with the Patient Care Innovation Center, PCIC in Houston, one of the things it is doing is building a database that integrates the medical record, electronic health record, EMR, whatever you want to call it, with a lot of other kinds of data. There's also, there are a lot of programs now that are collecting social determinants or determinants of health data that are being embedded into electronic medical records. And if we can get to the point where you look at a person's health in a holistic way, you would insist on seeing more about that person than just what their medical records show. And slowly but increasingly, we're seeing that take hold, and I see it a lot in the community clinics who are providing primary care and who are recognizing that they're not able to solve the problems that patients are presenting with because the problems are not medical in solution, they are social and community based in solution. And so they are gathering other information and doing a good job without much compensation to make sure that people actually get to access other kinds of services that will actually improve their health when healthcare won't do that. And the IT component is really critical because that's what will allow you to look holistically at a patient. And ideally, if you do something like what PCIC is trying to do across all of the various providers who are serving a particular patient, whether they're a medical provider or social service provider or transportation provider.
And we're doing a lot at our department around innovation and bringing the technology solutions together. But I think that challenge is really how do you continue to merge in healthcare systems with public health systems and ensure that you have not proprietary information, challenges that folks don't want to, entities don't want to always share everything because of a competitive advantage, but really bring it to the improvement of the population's health. And I think that's the ongoing tension. After Hurricane Harvey, I think we've seen some opportunities to, again, to the comments that were made by both of my colleagues here, of opportunities to work together, which is very similar to what happened after Hurricane Katrina, opportunities to work together. And I would really think that on the innovation and the technology and the data side, that's going to also be an opportunity to work together based on some of the lessons that we get out of Hurricane Harvey.
Yes, ma'am.
Okay. I've been thinking about groups that are particularly vulnerable during natural disasters, so like undocumented or mixed status families. So at several events in the TMC, I've heard concerns raised that immigrants are concerned about coming forward to get help, which includes medical help during natural disasters because of all these fears with the political climate and SB 4. So how do you address these fears and make sure people actually get access to help?
Since I'm not a health provider, I'd have to defer, but I can say that those concerns are something that I'm absolutely aware of and that the hospitals have made known to me that the immigrant population feels like it's been pushed to the shadows, and so at the end of the day, they're not going to come in for regular dialysis treatment. They're going to end up in the emergency room costing all of us more money. So it's an absolute legitimate problem. And the only thing that I can think of right now is that because we really only lost one hospital because of Harvey, only one hospital is closed and it won't reopen, that the community doesn't have to worry about rebuilding physical buildings and can go out and get, I guess, more involved in the community to try and make people as a provider feel comfortable to come in to get services, that they're not going to be deported or reported in any way because they're coming in for a routine dialysis. So I think it's actually going to have to be boots on the ground from providers or representatives of providers.
Yeah, and what we're hearing is that the providers are on board. The providers are welcoming, but people are afraid, and they're afraid even of their trusted providers, and they're not afraid that their providers are going to turn them in, but they're afraid that healthcare facilities will be targeted by people either under SB4 or federal authorities, and that is making people nervous. Next week, we will be publishing a very large study, a survey that we have conducted with the Kaiser Family Foundation about Harvey, and it's a large survey of the entire Harvey region that looks at pretty much everything in the world post-Harvey. But we included particularly immigrants and undocumented people because we wanted that voice to be heard. And the reason we have conducted this survey is because we want there to be data out there that those who are distributing funds, whether it's governmental funds or the philanthropic funds that have been raised, that those can be distributed in a way that actually reaches everybody, because we have been distributing funds in ways that are not necessarily going to reach everyone in need. And so the data that we're producing is important for that reason, but it's especially important because we were able to include the voices of people that are not otherwise going to be surfacing in terms of what their needs are. And I hope that that will be informative to those making decisions about recovery resources.
Yes, sir.
Thanks. A very insightful conversation. I'm Dan Hackner. I'm a physician and care management professional. And as you're doing today, you're sharing good information, which is very low-hanging fruit to make change. And we've done a lot better since even the Tax Day floods and Memorial Day floods and sharing information. But as Representative Davis indicated, following the initial landfall of Harvey, places like community dialysis centers were not only closed in many cases, but we had no information about which ones were open, such as one near the medical center and others that were spottily covered. And then if we went on to home health organizations, the 10 major and 600 plus mom and pop operations, we had very little information on who was open, their readiness, their capacity. Any thoughts on how we can do a better job at assessing and sharing capacity and capability information, yes, in the event of a disaster, but also an assessment of those health resources and the state of our, not just services, but our capacity to care?
You know, one shout out that I'd like to make before getting deep into your question is SETRAC, Southeast Texas Trauma Regional Advisory Committee, which was very instrumental in coordinating healthcare resources across the community, including the transports of patients for a variety of medical issues, including dialysis, but a variety of medical issues. And I really want to say that and as we're describing the Harvey experience nationally, a lot of systems out there, a lot of communities that don't have a SETRAC type of arrangement or relationship are dumbfounded of how incredible that system was. However, to your point, we can always do better, and there are more things that we can do to ensure that we have coordination across the system. I think one of the challenges on the dialysis side, there are a number of challenges, but one of the dialysis challenges was that as centers were open, the center may have been open, or the communication that the center was open may have been there, but the actual road to get to the center, you know, if you have a patient that's going 15 miles to get to the center, now, you know, some X highway is underwater, it was really challenging to figure out the crossroads to get there, physically to get there. So I think the challenge is really to get all of this information and really have it available in a way that the right people are making the right decisions with the right information. And so, you know, with the Office of Emergency Management at the county, working alongside the city emergency management, I think there are a lot of strides that were made during Hurricane Harvey. But your point is a good one, which is, yes, we have a great system when it comes to CETRAC and some of the regional coordination of medical assets, but we can do better, and we need to continue to focus on those gaps. So I would just say that that is one thing that we're looking at as well.
Yeah, I couldn't agree more. The first thing I thought of was were the racks. I've done some legislative work on racks, trying to bring them into a current century, because they were created, you know, about 25 years ago, trying to create hubs so that they're not, so that there's a more community or more relationship between the racks. We are very lucky because CETRAC is amazing. And so, to your point, though, that's one of the things I was thinking is what role could a rack play with these freestanding dialysis centers, or with people that are technology dependent and disabled? You know, if they have no electricity, obviously that's going to be a life and death situation. So now, I'm not an expert. I'd always want to go talk to the racks first, but that was the first thing I thought of, because we just have an incredible rack in our area.
Yeah.
And the clinics, actually, so I do a lot of work with safety net clinics, and I spent a lot of Harvey at the George R. Brown, and we had two meetings, actually, that Dr. David Peirce and I coordinated. CETRAC and Peirce brought in the hospitals, and I brought in the community clinics. And there was excellent communication there, and we actually had a conversation about why isn't there the sort of the CETRAC version for clinics, because we used to have something like that and it fell apart due to its own weight. I think you raise an excellent question, and CETRAC has been an outstanding model. It's been around for a long time. It's also mandated, and the same thing is not true with respect to all of these disparate clinics.
And the complement to what was happening at GRB was that at NRG, we had Harris Health System. We also had Harris County Medical Society, an incredible group of volunteer physicians. So thank you if you were one of them. It sounds like you were, from that standpoint of really helping coordinate. But also, you know, we were getting some folks from, you know, Maryland. Hey, I'm a doc, I want to show up. And Harris County Medical Society had already sent out this incredible massive text and email and fax campaign. We had so many physicians and nurses and healthcare providers locally that we really didn't need the assistance from folks who, at the end of the day, really could help Florida or could help Puerto Rico. So I think we were very fortunate for that kind of asset as well.
And we're going to do one last question.
Yeah.
We're really good at disasters.
Yeah.
From the healthcare side. We are. We are very good
practice.
at it. Yeah.
Thank you. My name is Ashley Dudman. I am in community health, and I have a background in public health. And we know that public health is focusing on the populations and the communities in which people live, work, and play. In that health system that you mentioned, how important is collaboration with the individual, the community, and the population regarding behavior change, leading to self-efficiency? We know that individuals in our community are all at different stages in identifying where they are in behavior change, and to identifying where they are, their perceived barriers and the perceived benefits to those changes. So how important is that collaboration within that health system that you spoke to?
Yeah, absolutely. I think you hit the great last question, because that was fantastic. Yeah, you're studying? Getting it? I have an MPH. Okay, so come work with us. I think that's we'll recruit you. That's a great question. And you know, I what I would say is that in our minds, we say, let me back up. It's not just we say. Health happens where you live, learn, work, worship, and play. Health happens in the community. It doesn't happen in the healthcare system. Doesn't happen in the emergency department. Doesn't happen in the clinic. There are parts of health that happen there, absolutely, but it really happens in the community. So as a doctor, if I tell you, hey, go exercise, and you've got a dilapidated park and you got dangerous dogs, or you're about to get bitten by mosquitoes, you're not going to exercise, you come back 3 months later, I say, you're non-compliant. But I haven't really addressed those social conditions, those conditions in where your community is. And so this is really something that's absolutely critical. And the reason that you bring this up at the very end so nicely is that the social factors and what happens in the community are absolutely essential, but behavior change is very difficult, right? So we are in Houston, Harris County, right? And as of, I guess, of 5 years, we were the fastest growing county in the U.S. And then last year we took a back seat to be number 2 to Maricopa County, Phoenix area. So now we're the second fastest growing county in the U.S. And that's incredibly important because when we are getting messages out to the community, we have people that it was their first mosquito season. This was their first hurricane season. So while the 3 or 4 of us may believe, oh, wow, we've gone through this many times, or I remember this storm, I remember that storm, I remember... We have people that just got to Harris County this morning, today, and they don't even know what Hurricane Harvey was, right? And so the job is to continue to get those messages out, but it's not just getting the message out, it's how do you get people to act upon those messages to change behaviors. And I don't believe we have got that fully figured out, and so I'm looking for some help, so please come and work with us. But seriously, we really do need to work on that behavior change because that's the real challenge is how do you go from theory of here's what I've heard to practice of here's what I'm going to do.
Awesome. That's our time. I want to thank the panelists so much for coming and thank all of you for coming.